All right, good morning, everybody. We want to welcome all of you to the New Hampshire Insurance Department's annual hearing on premiums in the insurance market. Our hearing is an opportunity to present findings on the insurance marketplace and create a forum for any related topics. Let's quickly take care of some housekeeping. Coffee and snacks are available just outside the door. We'll take another break at 10:10, and all those snacks will still be out there for you. Restrooms are just about 50 feet down the hall this way. There's 3 of them that I noticed down there. Today's event is being recorded and is being viewed through internet live stream. Next, I would like to recognize the following staff from the department. Alex Feldwebel, he's right here. Tyler Brannon had to leave pretty quickly for a family emergency. Hoping to see him back. Al Kuchar, yep, there he is. Jennifer Patterson is over here. David Sky is right here. Michael Wilkie. Maureen Mustard. Ariana Spell. There she is. And project manager Martha McLeod. There she is. And I noticed Christy Rice here is our director of HR, and that's mostly to keep Alex in line. So I wasn't supposed to tell her she was here. I'd also like to recognize some staff of Gorman Actuarial. Jen Smagula, right here. Don Gorman, and Linda Keene. There we go. The department has released a preliminary report developed from data received, and a final report will be available early in December. The reports can be obtained from our website. There's also a 2-page summary of the report finding, and it's available in the area where you came in. Additionally, we have copies of a Wall Street Journal article on hospital deals and consolidation. That article is relevant to the discussion during the carrier panel, and that is also available right outside. We're going to begin with a presentation by Gorman Actuarial on health insurance premiums and our insurance market. After the Gorman presentation, we will hear directly from our carriers. The carrier panel will focus on consolidation in both the insurer and provider industries. After the carrier panel, we hope to have a presentation by the department on carrier provider discount study. This is an analysis of the discounts obtained by carriers in New Hampshire and provides insight about the competitiveness of the marketplace. A public comment period will be permitted at the conclusion of the department presentation. Okay, let's get started. First, I'd like to introduce Jen Smagula, who will present the annual hearing findings for Gorman Actuarial. Jen?
So I'm Jen Smagula. I'm a healthcare actuary working with Gorman Actuarial, and I'm joined here today by Don Gorman and Linda Keene. And I'm going to take you through this presentation on the key findings from our preliminary report on New Hampshire's 2017 healthcare premium and claim cost drivers. So the goal of the report in the presentation is to examine health insurance premium and claims costs and the factors contributing to changes in those costs. This year's focus is on 2017, but we'll also be presenting some information from 2018. So first, to start with an overview. The uninsured rate in New Hampshire has decreased almost 5 percentage points from a high of 10.7 in 2013 down to 5.8% in 2017. So during this same time period, the United States uninsured rate has also experienced a similar decrease from a high of 14.5 down to 8.7, but the U.S. uninsured rate remains higher than the New Hampshire uninsured rate. And this chart also points out some of the significant impacts to the New Hampshire health insurance market over the past several years. So this includes the implementation of many of the major provisions of the Affordable Care Act, which happened in 2014, Medicaid expansion in New Hampshire, which happened in August of 2014, and then the conversion of the Medicaid expansion population to the premium assistance program, or New Hampshire PAP, on January 1st of 2016. So as of that January 1st, 2016 date, all of those Medicaid expansion members became part of the commercial individual market, and they were rated under the single risk pool requirements of the ACA. So they were included as part of the individual market rating pool. Individuals eligible for the New Hampshire Premium Assistance Program generally include adults aged 19 to 64 with incomes up to 138% of the federal poverty level who aren't otherwise eligible for Medicaid or Medicare. So, and as we'll discuss more further in the presentation, there's a couple changes that have already happened or are going to happen in New Hampshire that will impact the New Hampshire health insurance market. So one that's already happened is the closure of Minuteman in 2018. So Minuteman was a lower costing option in New Hampshire that primarily served the individual market. And the second change is the migration of the New Hampshire Pap population out of the commercial insurance market to the Medicaid MCOs, which will happen in 2019. Now, this first change, the closure of Minuteman, could result in an increase in the uninsured rate in future years based on what we've seen so far in the early 2018 data, and we'll see some of this information in upcoming slides. So these next couple slides compare New Hampshire or average New Hampshire premiums to other states and to the US average. So this first slide looks at the individual market and uses publicly available data from the CMS risk adjustment reports. So in 2015, New Hampshire individual market average premiums were about 4% higher than the US average. So the blue line, the blue bar is New Hampshire, the red line is the US average. Now, looking ahead to 2017, this relationship has switched. So New Hampshire average premiums were 19% lower than the US average, and they were actually ranked 10th lowest across all states. Now in the US, the average premium increased about 21% from 16 to 17, and consequently, total enrollment in the US decreased. So total enrollment in the individual market in the US decreased about 10% from 16 to 17, and that was driven by about a 20% decrease in those members who do not receive any type of subsidies, the members who are paying the full premium. Now in New Hampshire, from 16 to 17, we saw about a 6% increase in individual market premiums, and the 2017 enrollment did not change very much. But again, looking ahead to 2018, where we are already seeing in New Hampshire membership decreases as premiums increase, this relationship between the New Hampshire and how it compares to other states in the US might change. So this next slide looks at the small group market, and it's using the same publicly available information from the CMS risk adjustment reports. So in 2015, New Hampshire small group market average premiums were about 6% higher than the US average, and they ranked 10th highest across all states. And looking ahead to 2017, New Hampshire small group market average premiums were about 2% lower than the US average and ranked 20th highest. Average premiums in the US increased about 4% from 16 to 17, which was very similar, only slightly higher to what we saw in New Hampshire small group. Those premiums increased about 3% from 16 to 17. Now this slide compares the large group average single premiums in New Hampshire to the US averages and to other New England states. So CMS risk adjustment does not apply to the large group market, so we don't have that same data available to us, but here we're using data from the Medical Expenditure Panel Survey, or MEPS. So the United States is colored in black, New Hampshire is colored in red, and then the other New England states are showing up in other colors. So this shows that in the large group market, New Hampshire is consistently higher than the US average premiums, but they're in the mid to lower end when you compare them to other New England states in 2017. Now in 2017, New Hampshire premiums were about 3% more than the US average. Maine has the lowest premiums of all the New England states in 2017, and Rhode Island and Connecticut had some of the highest average premiums in this market at about $7,000 per enrollee per year. And note that the premiums shown here and throughout the report include both the employer part that the employer would contribute to the premium and the employee contribution. So these next two slides that I'm going to show you also use MEPS data, but now we're shifting our focus. Instead of looking at premiums, we're looking at average deductibles. So deductibles are one form of cost sharing that's common to many healthcare options. So this shows that in the small group market in New Hampshire, single deductibles are significantly higher than the US average. They're about 45% higher in 2017. And they're consistently higher than most other New England states. So Maine's average deductibles, that line in blue, they're following pretty much in line with New Hampshire, while Massachusetts and Rhode Island have some of the lowest average deductibles in this market. And this last slide in this section shows, now does a comparison of New Hampshire large group deductibles to the US and other New England states. So in the large group market, New Hampshire deductibles are about 20% more than the US average in 2017. New Hampshire and Maine, Maine again is in blue, they consistently have higher average deductibles than the other US states, which is similar to what we saw on the small group slide. Now the scales on this slide and the slide I just showed you, so the scales are the same. So this just kind of looking at both of them gives you a sense that the small group market, first of all, generally has much higher deductibles than the large group market. They go up as high as $3,500. But also there's much more variability in the small group market. The spread of deductibles by state is much wider. When you look at the large group market, it's a much tighter range. All right, so we are now going to move on to talk about some coverage shifts. And by coverage shifts, we mean we're looking at shifts in enrollment within the health insurance market, and these could be shifts by market segment or by insurer or just overall. So this slide gives an overview of the New Hampshire commercial insurance market from 2015 to 2017. And by commercial, we mean people who purchase insurance either on their own or they receive it through an employer. So on the left, this is a gray bar that shows the proportion of membership for each commercial market segment in 2017. So note that almost half of the insured commercial market, or the 48.9, which is that bottom gray bar, they're enrolled in large group self-insured plans. Now, similar to prior years, we see that the majority of membership is getting their health insurance coverage through their employer. So this consists of that large group self-insured market we just talked about, the large group fully insured market at 19.8%, and then the small group market at 12.6%. So the right side of this chart in colors shows the enrollment by market segment over the past 3 years. So for instance, the New Hampshire Pap market, which is that second gray bar down, they were new to the commercial market in 2016, and they're currently at around 42,000 members, or about 8% of the total commercial market. So as of January 1st, 2019, that's the population that will no longer be part of the commercial segment. Now, another item to note is enrollment in the small group market has decreased from 2016 to 2017. So that's that third set of colored bars. Membership there has decreased about 7%. And the small group market consists of those employers with 50 or less employees. So this slide takes a closer look at the small group market where we saw the membership decreases, and it looks at market share by insurer. So while overall membership in the small group market is decreased, we can see that market share for Anthem Matthew Thornton, which is shown in blue, has stayed pretty consistent at 44%, while Harvard Pilgrim has grown their market share in this segment from 46 to 50%, and their Harvard Pilgrim shown in red. Now, Tufts was a new entrant to this market in 2016, and we can see that they are gaining market share. They're the purple piece of the pie in 2017 at 5%. Now, on the flip side, Community Health Options exited the New Hampshire market in 2017. So you can see their market share going from the 9% in that light blue to nothing in 2017. So Community Health Options, or CHO, was a lower costing option in this market in New Hampshire that was available in 16. That's no longer available. So small group employers may have dropped coverage when CHO was no longer available. And our data also shows that the decreases in the small group market are coming primarily from the 2 to 25 segment, so employers with 2 to 25 employees, so the smaller of the small groups. And we know that CHO was more highly concentrated in that smaller of the small group segment. So up to this point, we've been focused on membership and information through 2017, but now this takes a look at what's going on into 2018. So this slide compares membership from April of 2017 as of April of 2018. And when looking at this data, we see there's about a 10,000 membership decrease in the individual market segment during this time frame, driven by a loss in the non-exchange portion of the individual market, so the red piece of the pie. And those are the members who they're not receiving any type of subsidies. They're full paying members within the individual market. Now, due to the high premium rate increases that occurred in the individual market in 2018, and knowing that with the closure of Minuteman and them being a lower costing option in 2017, many enrollees may have dropped their health insurance coverage during this time or tried to find it elsewhere. And one item note is that when you look at the small group and large group segments, they've actually been fairly stable so far based on what we've seen into 2018. So we've shown this slide in the past, but we feel like it's a good way that really demonstrates how diverse the individual market is and all the different subpopulations. So this slide starts with the 94,000 members who are in the individual market as of April 2018, and it shows all the different breakouts. So for example, on the left-hand side, we see the 10,000 non-exchange members, and then it further breaks it out into 6,000 of those members are part of the grandfathered transitional population, and 4,000 are part of the non-grandfathered population. So those 6,000 grandfathered transitional members, they are not part of the single risk pool that we've talked about. They are rated separately from everyone else in the individual market. Now on the right-hand side, we start with those 84,000 members who are getting their health insurance through the marketplace exchanges. That includes 41,000 who are in this New Hampshire Pap population, and then another 43,000 who are not in the New Hampshire Pap population, but could still be getting other federal subsidies. So of those 43,000, we can see 18,000, they're getting cost-sharing reduction subsidies and federal premium subsidies. 15,000 are not getting the cost-sharing subsidies, but they're getting the premium subsidies. And the remaining 10,000 are they're purchasing coverage on the exchange, but they're not getting any type of subsidy. So the segments outlined in blue, these are folks who are not getting any type of subsidies, and the segments in green, they're getting some type of subsidy for their coverage. So this slide gives another view of the changes that we're seeing in 17 into 18. So consistent with the previous slide, the bars shown in green are getting some type of subsidies, and that includes the New Hampshire Pap population, and the bars in blue are not getting any type of subsidy. And it's in the blue segment where we're seeing the largest membership decreases. So in 2017, we see about 23,000 people in those two blue bars who are not getting any type of subsidy, and that decreases to about 14,000 in 2018. So due to these shifts among the population, the individuals receiving subsidies, the percentage of individuals receiving subsidies is increasing. We can see that in 2017, about 74% of this market are getting some type of subsidy, and that increases to 84% in 2018. Now, this slide uses data from the All-Payer Claims Database in New Hampshire, or also known as the New Hampshire CHIS database. And it looks at each of the insurers who had the majority of the individual market membership, excluding the PAP folks for a minute, and it looks to see what happened to them in 2018. So in the case of Minuteman, which is on the right side, we can see that about 35% of those Minuteman members who were in the market as of 2017, 35% of them have dropped health insurance and are no longer have health insurance benefits in New Hampshire. The remaining 65% of those Minuteman members did find health insurance elsewhere. A lot of them we can see did shift over to Anthem, Matthew Thornton. Now with Harvard Pilgrim, which is shown on the bottom right in red, they also had a fairly large portion of members drop coverage. About 24% of them dropped coverage. 38% found coverage elsewhere, and the remaining 38% in the solid red stayed with Harvard Pilgrim. And then lastly, the top left, we have Anthem. So they experienced the smallest amount of members dropping coverage completely. Only about 10% of their members left the market. So given the number of members who have dropped coverage so far in early 2018, it is expected that this will eventually impact the uninsured rate. And also knowing that Minuteman attracted the healthier risk members, and it's the Minuteman members who are left at the highest rates, it is expected that eventually this is going to play out in higher claim cost trends. So this chart looks at the increase in the second lowest costing silver plan from 2017 to 2019. Now, rates and rate changes for the second lowest costing silver are often reported as this plan represents the benchmark plan for which premium subsidies are based off of. So from 2017 to 2018, the change in the second lowest costing silver was about 78%. Now, the change in the second lowest costing silver from 18 to 19 came down 15%. So the overall, this translates to a change of about 51%. And what's driving that decrease from 18 to 19, a big part of it is due to the fact that in 19 is when the New Hampshire Pap population has migrated out. So that's causing a lot of the decrease. But still, when you look at this over this 3-year period, that's an overall rate increase of 51%. And the rate levels in 2019 are still much higher than 2017. So it's not anticipated that the members who left in 18 are going to come back in high numbers to this market, given how price sensitive this market is. So the last slide in this section is going to shift our focus to the large group market and the mix between fully insured and self-insured business. So the primary difference between a self-insured and a fully insured arrangement is that under a self-insured arrangement, it's the employer who assumes the risk of the healthcare claims of its members, while under a fully insured arrangement, it's the insurer that's assuming the risk of those members, and they charge a risk premium in order to take on that risk. So when an employer is making a decision about whether to self-insure versus fully insured, some of the questions they'll consider is that employer large enough to smooth out the volatility in healthcare claim cost expenditures? And is that employer able to absorb an unexpected high-cost claim? And lastly, will the savings that the employer expects under a self-insured arrangement, is it enough to take on all that added risk that comes with the self-insured arrangement? So as shown by this chart, each insurer's strategy does vary. So Cigna, for instance, their primary focus in New Hampshire is the self-insured segment, which is shown in red. So about 92% of of Cigna's large group membership in New Hampshire is from self-insured. Now, Anthem, they have more of a mix. About 70% of Anthem's membership is self-insured. The rest is fully insured. And then Harvard Pilgrim, it's more split, half and half. But overall, we see that within the large group segment, about 71% of the membership is self-insured. And note that state regulatory agencies like the NHID have very little rating authority over self-insured business. So now we're going to look at data for premiums and cost sharing in New Hampshire. So this slide gives a picture of what happened to premiums within the various segments in New Hampshire over the past 3 years. So overall premiums in the fully insured market have increased 6.7% from 2016 to 2017. When you look at the individual market on the left, they experience a premium increase very similar to what they've seen in the past, so the 6.2 and the 6.8. The small group market premium trends have come up from what they saw the prior year, so the 2.7 versus the prior year at the negative 1.0. And we did see in the small group market in this in the current time period, they did have benefit buy down, so members were switching to plans with higher cost sharing, and that helped keep the premium trends lower than they otherwise would have been. In the large group market, their premium trends have also increased this year from the 4.4 to the 5.5, and in that segment we saw very little benefit buy down. Now, based on a 2017 employer benefits survey from the Kaiser Family Foundation, average premiums in the employer market nationwide increased about 4% for single coverage and 3% for family coverage. So when comparing these to the results we're seeing in New Hampshire, they're in the ballpark. The small group market is on the lower end of that range, and then the large group premium trends are above that range, the 5.5. They're higher than what, slightly higher than what happened nationally. So this slide takes a further drill down into what's happening in the individual market when it comes to premiums. So again, overall premium trends in the individual market increased 6.8%. And we saw the largest increases occurring in the non-exchange and the grandfathered transitional population. So the non-exchange is the second set of bars. They saw a premium increase of 12.2, and the grandfathered transitional saw an increase of 13%. Now the exchange population, which is over on the left, they saw an increase of about 7%, and they represent a large portion of this market. They represent about 44% of this market. Now, when we look within the exchange population, we did see a lot of shift over to Minuteman products, and again, those are the generally lower costing options that were available in 17. So that helped keep premium trends lower in the exchange market versus the non-exchange market, where Minuteman didn't have as much of market share. So now this looks at average deductibles within the New Hampshire market over the past 3 years. So on the left side, we start with the individual CSR population. So CSR are the cost-sharing reduction subsidies for qualifying low-income individuals who have 250 or below 250 of the federal poverty level. So these cost-sharing reduction subsidies allow individuals to have lower deductibles along with lower co-pays and low co-insurance, and they still pay a fairly low premium. So these members on the left side, the ones getting the cost-sharing reduction subsidies, have some of the lowest deductibles in the market. So their average deductible that in this 2017 year was $1,184. So this is much lower than the deductible for everyone else in the individual market, what we've labeled the individual non-CSR folks. So the individual non-CSR folks, they have an average deductible of about $3,950, and that's about 3 times more than what the folks with the CSR are getting. Now, when comparing the individual non-CSR to the group segments over on the right, you can see that they're also higher than the group segments. So the non-CSR deductibles are about 22% higher than small group, 30% higher than large group, and they're almost 5 times greater than the deductibles in the self-insured large group market. Now, about half of that large group self-insured market, which is shown on the right, about half of that segment is made up of state and municipal plans. So looking at all the data, we can see that deductibles have increased in all segments from 16 to 17, but it's the large group self-insured segment that saw the smallest decrease. Their deductibles only went up about 1.4%. So the last side, we are focusing on deductibles, which is just one form of cost sharing that's tied to a plan design. So this slide looks at average cost sharing that's actually paid by members in each of these segments. So it's their total out-of-pocket costs for the year. And this can include all the deductibles, but it also includes whatever co-pays and co-insurance they were also paying. So similar to what we saw on the deductible slide, we have seen that paid member cost sharing has increased in all segments from 16 to 17. And the relationship among segments is similar to what we're seeing or what we saw on the deductible slide. So the self-insured members are paying the lowest amount out of pocket per year, followed by the individual CSR, and the individual non-CSR folks are paying the most during this time period. So that individual CSR population, the second set of bars, their out-of-pocket costs represent about 25% of the total medical spend. And this compares to, if you compare them to the individual CSR, those folks are paying about 12% of their total medical costs out of their own pockets. And then again, comparing on the right-hand side the large group fully insured to the large group self-insured. The large group self-insured, what they're paying out of pocket is about half of what the large group fully insured members are paying. So the last slide in this section looks at the relationship between premium and benefit richness. So the paid to allowed ratio, which is shown on that y-axis or the vertical axis, that's an indicator of how rich a health insurance benefit plan is. So the higher that ratio, the closer it is to 100, the more rich the plan design is and the less the members are paying out of pocket. Now the x-axis or that horizontal axis, that is the premium PMPMs that were actually paid out. And each bubble in this chart represents a different market segment. So this chart is mapping benefit richness versus premiums. So for example, the dark blue bubble that's over on the right, that is the large group market, fully insured market. So they have the highest premiums because they're further along the axis. They have their average premiums are about $525. But however, they're also situated above the small group and individual CSR segments, so they have richer benefits. So they're paying higher premiums, but they have richer benefits. Now, by contrast, we have the individual non-CSR, so their premiums are lower than the other two segments in blue, but their benefits are also less rich. They're lower on this chart. Now, the two bubbles in green, those are the two segments whose premiums are subsidized, and they have other cost-sharing type of subsidies. So the New Hampshire Pap is shown way up near the top of the chart, and we also have the individual CSR. So this shows they have the most comprehensive or richest set of benefits out of all the segments within New Hampshire. So now we talked about premium and cost sharing, so now we're gonna talk about actual claims costs. So trends in the total fully insured market have in total come down in 16 to 17. So last year we saw trends of around 6.4%, and they've come down to 4% in this time period. Now you can see a lot of this is driven by what happened in the individual market. So the individual market, which is on the left, they saw a really big spike up in claims trends in 16, and then it's moderated into 17. So that big spike up in claims, that was when the PAP population came into the market. Now, if you just look at the small group, large group, which is combined in the middle there, their trends have come up slightly. So they were trending at 2.8% last year. Now they're at 3.4%. And then over on the right, we're showing the self-insured segment. So they have the highest trends of all the segments in this time period at the 5.9, and their claims levels are also a lot higher than the other segments. So this chart takes that combined 3.4% small group and large group trend that we saw on the previous slide, and it breaks it into two components. So one is utilization, and the second is cost and mix. So utilization is the number of services provided, and unit cost and mix is the increase in price for those services, and increases due to the change in mix of the services or change in mix of providers. So utilization trends have actually come down slightly from 16 to 17, so the 1.2 to the 0.7, while cost and mix trends have come up, the 1.5 to the 2.7. And what we're showing on the right is when we look back over the trends for these 3 years, what portion is driven by utilization and what portion is driven by cost. So you can see it's really the cost and mix trends that are driving trends. About 88% of trend is driven by cost and mix, 12% is driven by utilization. So within that cost and mix bucket, we know from data collected from the insurers, the mix portion of that, it's fairly small. It's about negative 0.5% to positive 0.5% during this time period. So if you were to back that out, it's really the cost, the unit cost or price increases that are driving trend over this time period. And then we went back and looked even farther. We went back, we have data like this back to 2011, and it's consistent when you look over this long time frame. It's consistently cost that's driving trends. And then we compared to what other states were seeing, and even nationally, so states like Massachusetts, and then information that's available nationally. And the story is very similar. When you look over the past several years, it's cost that is driving trends. So this slide looks at which service categories are contributing most to trends over the past couple years, and this is still focused on just the group markets right now. So when we look at trends from 16 and 17, the main drivers of trend start with outpatient facility costs, followed by inpatient facility and professional services. So this is a change from what we saw when we looked at this last year, where it was pharmacy was a big driver of cost. When we looked at this last year and looked at trends from 14 to 16 in last year's report, the largest contributor was pharmacy, and it was contributing about 1/3 to the overall trend increases. But you can see here that's given some of the trends coming down on the pharmacy side, pharmacy's impacting trends about 8%. So now this slide takes a deeper dive into pharmacy and some of the different components. So, and this is we're still in the group markets right now. So pharmacy trends in 2017 were negative 0.5%, or means it was fairly flat. There was very little change from 16 to 17. And we can see a lot of this is driven by the lower specialty pharmacy trends that happened in 2017 versus 16. So last year, specialty pharmacy trends were 17.5. Now we're seeing they pretty much cut in half. They're about 9.1%. However, as you can see, specialty pharmacy, it's still the biggest bucket within pharmacy. It represents about 41% of pharmacy costs, and their trends are much higher than what's happening on the non-specialty side. Now the right side of this chart, this shows the pharmacy costs that are coming through the medical benefit. So this includes prescription drugs that are administered at a hospital or in a doctor's office. And in many cases, these are high-costing injectables. So we can see the trends for these drugs have also decreased in a somewhat similar manner to what we saw on the specialty drugs coming through the pharmacy benefit. So this, on the right-hand side, those drugs coming through the medical benefit, the trends went from 12.2 to 4.8. Now overall, pharmacy costs on the traditional pharmacy coming through the pharmacy benefit represents about 18% of total costs. Now the pharmacy under the medical benefit, that represents about 7% of total costs. So combined, all these pharmacy drugs represent about 25% of total medical spend. Now, with regards to the lower pharmacy trends that we saw this year, in addition to lower specialty trends, the insurers also pointed out other drivers, including lower utilization, better pricing, and then increased rebates. And what we're seeing in New Hampshire does seem to be in line with what's happening nationally. A lot of the PBMs reported that their trends in 2017 were some of the lowest that they've seen in the past several years. So throughout this report, all of our pharmacy data is represented net of the prescription drug rebates, but we wanted to show the how much rebates represent and how they're impacting our trends. So rebates are the amounts that are paid to the insurers from drug manufacturers, and it does help to reduce total pharmacy costs. Prescription drug rebates have grown at a faster rate in 2017 than overall pharmacy costs, so this is helping to keep the pharmacy trends down. So in 2016, what's shown on the left side, these are the pharmacy cost gross of rebates, so before we've subtracted out the rebates. And we can see that the 2016 trend was 5.8% gross of rebates, but once you take out the rebates, it's 4.8%. So that's about a 1 percentage point drop. Now looking at 17, the trend gross of rebates was 1.2, and then once you back out the rebates, the trend is that negative 0.5% that we've seen, and that's about a 1.7 percentage point difference. So this slide also gives a sense of how much rebates are worth. So in 2017, the difference between that 101 gross of rebates and the 88 net of rebates, that's about $13 PMPM. That's how much rebates were worth this year. And that represents about 12% of gross pharmacy costs. So now we're going to shift our focus to drill into the individual market and what's happening with trends there. So we saw that overall allowed claim cost trends in the individual market have come down a lot because of driven a lot by that first year of the PAP coming into the program. So the 21.3% versus now it's down to 4.9%. And we can see when you look at the different segments, it's within the non-exchange and the grandfathered transitional, which are experiencing some of the highest trends. So the 6.6 in the non-exchange population and the 9.2 in the grandfathered population. And when we dive into the information, it's driven, their higher trends are driven by inpatient facility and outpatient facility services. But we also note when looking across all these categories, pharmacy is a large driver of trend in the individual market. And then another thing to point out, so the New Hampshire Pap population is the set of bars right in the middle. So you can see, while they're trending at a similar rate to some of the other segments, their claims level is much higher than the other segments. So they're at the 548 in 2017 compared to most of the other segments are in that 400 range. So this slide now digs into the pharmacy side of the individual market. So in the individual market, pharmacy trends were 16%, while remember back to the group market, those trends were pretty flat or that negative 0.5%. And the individual market experienced higher trends in all of the pharmacy categories compared to the group market. But as was the case in the group market, we also saw the trends come down a lot in the specialty pharmacy in particular. They were trending at almost 37% last year, and now they're down to 14%. Now, when comparing PMPM levels between the individual market and what we saw in the group market, that the individual market PMPM, that 108, that's about 23% higher than what's happening on the group market side. So while overall pharmacy trends have come down even in the individual market, they're still very high at 16%, and the pharmacy levels within the individual market are still much higher than what's happening on the group segment. And I should also point out, so this actually excludes the PAP population, but when we look at the pharmacy costs for the New Hampshire PAP population separately, they have very similar pharmacy costs to the non-PAP population, but their mix of drugs is different. The PAP population is actually using more non-specialty, brand non-specialty, and they're using less specialty than the non-PAP population. So the last two slides in this section looks at two key utilization metrics. One is inpatient admissions, which is what is shown here, and the second one we'll look at is emergency department use. So overall inpatient admission use has increased in New Hampshire and within most segments except for that large group fully insured segment. And another thing to note is the New Hampshire PAP population, you can see they have much higher inpatient admissions rates than the other segments. While if you look at the individual population excluding PAP, their inpatient admission use is actually pretty much in line with the two group markets. And that line in the middle, we're using it as a benchmark point. So that's data coming from the Healthcare Cost Institute. So the most recent metric we have for them is from 2016, where they show in the group markets across the whole US, admits are about 50 admits per 1,000, which you can see the small group market is pretty much in line with that, and the large group market is slightly higher than that. So lastly, this slide shows emergency department utilization. So one very positive thing across the board, we've seen emergency department use decrease in every segment. So overall, it's decreased 5% during this time period. But you can see the New Hampshire Pap population does have much, much higher emergency department use than the other segments. So the last section we're going to look at covers some information related to medical loss ratios, expenses, and profits. So first off, we're going to start and talk about risk adjustment. So the risk adjustment program, what it generally does, it redistributes funds from insurers with lower risk or healthier enrollees, and it transfers money to those insurers who have sicker or higher risk enrollees. So health plans who have healthier members will end up paying, and those amounts are shown in red, versus the health plans who have sicker members and end up receiving money are shown in black. So this was the risk adjustment program's a permanent program under the ACA, and it's revenue neutral under the New Hampshire individual market and then separately within the small group market. So in the individual market, we can see, so Minuteman was assessed a $39 million payment for 2017 risk adjustment, which means they attracted much healthier risk than the other insurers in this market segment. But as a result of Minuteman's closure at the end of 17, risk adjustment payments from Minuteman to other insurance carriers is not expected to happen. So what does this mean for the other insurers? So as a result of the other insurers not getting their risk adjustment payments, they will all experience lower profit margins than they otherwise would have. So risk adjustment payments in 2017 for the individual market, it was expected to represent about 6% of premium for Anthem, Matthew Thornton, 11% for Harvard Pilgrim, 13% for Ambetter, for a total of about 10% of premium. So as a result of the non-payment, when you look across all these three individual insurers, on average, the profit margin is it would have been around 7%, and now as a result of the non-payment, it's about -3%. So we looked at the data earlier to show Minuteman's impact on enrollment in the market. So this gives a picture of the Minuteman's impact to other insurers in the market. So now this focuses on risk adjustment in the small group market. So in the small group market, the new market entrant Tufts will end up paying about 50% of the total risk adjustment within the small group market, so the $3.3 million in red, and Harvard Pilgrim will end up receiving about 81% of the risk adjustment payments, so they're shown the black, the 5.1. So this would suggest that Tufts attracted the healthier risk in this segment, in this time period, while Harvard Pilgrim attracted the least healthier risk. Now this looks at medical loss ratios within the group markets. So the percentage of premium that's paid for medical and pharmacy is about 85% in the small group market and 80% in the large group market. The profit margin in the small group market is about 3%, which is shown in purple, and that's very similar to what we saw last year. In the large group market, their profit margin is 7%, shown in purple, and that's a slight increase from what we saw last year. Last year it was 6%. So lastly, we're comparing loss ratios for the large group fully insured versus the large group self-insured. So we saw on the previous slide, in the large group fully insured segment, their loss ratio, meaning the percent of premium dollars that are spent on medical claims, medical and pharmacy claims, is 80% versus 93% in the self-insured market. So that's a similar relationship to what we've seen in the past. And as we were discussing earlier, so insurers in the fully insured market need to retain more of the health insurance premium because in addition to administering the benefit, they're also taking on all the risk of paying those medical and pharmacy claims. And also generally, self-insured accounts are much larger, and there's an economy of scale that's recognized that allows insurers to charge a lower admin fee to the larger self-insured accounts than they would to the generally smaller fully insured accounts. So a lot of information, but what we felt like were some of the key findings and key takeaways was that the individual market is shrinking in 2018, and Minuteman's closure is impacting insurers and the market in 2017 and then even beyond. Individual market rates are decreasing in 2019, but they're still significantly higher than the rate levels from 17. Individual market members who do not receive subsidies have the highest deductibles and they're paying the most in out-of-pocket costs. Now on the group side, we have seen that premium trends and claims trends are slightly higher in 2017 than 2016. The large group self-insured market represents close to 50% of the total commercial market, and they have much lower cost sharing and also higher claims levels than the other segments. And pharmacy trends are lower than what we've seen in previous years, driven by much lower specialty pharmacy trends. But in the individual market, we're still seeing that high pharmacy costs and pharmacy trends. So the full report is available on the website, so that gives even more detail and context around all of the information we presented. And I just want to thank again everyone on the NHID staff for all of the information and support, and all the insurers, many of you who are in the room, for all the information that you provide to put this together, along with the other stakeholders involved in this process. So at this point, we're going to open it up to questions from the audience. And I think you can just, raise your hand. And
so on slide 24, you talk about what members out of pocket, members cost share. Are those actually what's being attributed to the members? You used the word paid. Are they actually paying that? How much of that is being borne by bad debt on the part of all the providers?
It's my understanding the way this is reported to us, this is actually what's being paid by the members. I don't know if, would you just, okay.
That's true.
Yeah.
So the part that's eventually going to bad debt on behalf of those people who aren't paying the cost they're incurring, do we have any idea of what's happening in that trend?
We didn't have the slide here. We do work with DHHS and the Hospital Association to collect information on uncompensated care costs, and one category within that bucket is bad debt. And it's actually in our report in the appendix, but I don't have that slide here, and I'm not quite remembering what we saw in that category, but we've tracked that over time, and we show what that.
And that's for the hospitals, but it doesn't
Yes.
count for any of the other providers.
Right,
Okay,
right,
thank you.
yeah.
When you were looking at, thank you for this presentation. Excellent job. When you were looking at deductibles, did you look at how many deductibles include prescription deductible in the deductible payment, and would that impact the prescription drug trend? So do you know what the trend is for out-of-pocket pharmacy?
If you were to just look at the pharmacy deductible. Well, I guess what we found, it's actually very challenging to separate out medical versus pharmacy out-of-pocket costs because so many deductibles now apply to the full spectrum of cost. They're not, I think it's more rare that there's a separate medical and pharmacy deductible, or there's just a big mix, so we can't really track that separately. So this is just one component of cost sharing, but this just represents, I think I'm looking at Don, this is the deductible that, it's the single deductible on the policy. So it could cover pharmacy in some cases and it may not, but I think most likely in many cases it covers pharmacy. So I know that probably doesn't really answer your question, but it's difficult to it's very difficult to separate out-of-pocket costs for pharmacy versus medical when in today's world so many deductibles are integrated over both benefits.
I have a question from the live stream.
Oh.
Somebody asked about the contributors to trend slide.
I don't remember what that is.
The outpatient facility sites was listed as 40%, but what percentage are hospital out-of-patient departments versus ambulatory surgical centers?
That I do not know. We don't collect that level of detail, so I cannot answer. I mean, yeah, I don't. Some of the insurers might, folks that have a little more access to more detail might have some more information. But I mean, AmSurge is obviously a big portion of that outpatient facility bucket. So I guess you could suppose that. I mean, it's got to be one of the drivers, but I don't know enough to say how much. Oh, yeah.
Yeah, on that same slide, for inpatient facility, are there pharmacy costs wrapped up in that piece?
Yes, the way the pharmacy costs come through on the medical side, they could be showing up in different buckets depending on where they're administered. So yes, pharmacy could be embedded actually in almost all of the pharmacy on the medical side can be embedded in a lot of these categories.
So there was a slide early about the exit from Minuteman and so the folks who we assume just exited the market based on that one.
Yeah.
So just out of curiosity, I think you said that was based on the CHIS data, and so I'm assuming that you were sort of looking to see if people who were and Minuteman subsequently became enrolled in other plans. Not that it's a huge number likely, but I was just curious, is it possible that some of those folks may have gone to some of the small insurers that don't contribute to CHIS because they don't meet the thresholds?
Yes.
So there might be some coverage there that's in just small plans that we don't see. Is that
Yes.
right? Okay.
But I know from the data we collect, I don't know offhand for CHIS, but I mean, within our data we collect, I want to say upwards of 98% of the total market. So I imagine CHIS is probably very similar, but yeah.
A little bit of coverage could be happening in places we can't see.
Yeah.
Yeah, so it looked like you concluded that a large part or the majority of increases in rates was due to cost and not so much mix or utilization.
Yeah.
Have you looked at the state's ABCD data that they collect and looked at variation in cost for negotiated rates across providers and seen what kind of savings potential there actually is if you assume that utilization is, it looks like utilization is going down. Yeah, we're still paying more.
You mean the impact of provider price variation across?
Yeah, this hearing annually, the commissioner is saying that we're supposed to be looking at drivers of cost and figuring out why rates are going up.
So we do not have that data right here, but I know New Hampshire has done other studies looking at provider price variation. I don't know when the most recent one was, but I can speak to work in other states. Provider price variation is definitely a key driver of cost, and I think it's
Over 40 or 50%
yeah.
savings potential if you look at it.
If everyone were to move to the
Yeah,
same, which
that's
is not
not-
really
yeah, no, that's not
ever
realistic. I'm
practical, but
no,
yeah,
absolutely.
yeah, just as a yeah.
If you
Okay. I think, oops. Oh, sorry.
I just wanted to dovetail on what he's talking about. Providers in the state are, somewhat regulated in what they can charge, but no one's looking at the allowed amounts that these insurances are claiming are reasonable. We have insurances that are paying us under Medicaid rates and trying to tell us that it's based on marketplace. We can't possibly survive to take care of patients if we can't get a reasonable cost to even cover giving that service. And I think a big part of this is not attainable and it's not affordable. Everyone's forgetting the point that this is happening because people do not have the money. So when you're talking a $3,000 deductible, $5,000 deductible, and then you're talking hundreds of dollars for co-pays every month for medicines, especially ones that are for chronic conditions, how reasonable is that? It just doesn't make any sense. And no one's looking at what the insurance's responsibility is. We're always looking at making sure they get profit. I'm not against them having profit, but reasonableness where we all are working together. And it does not feel like that's what's happening. The patients are getting less and less. Providers are getting less and less. I just feel like we're missing that whole component.
I mean, I think the panel that's coming up later, I know it doesn't address everything you're talking about, but I mean, one of the main goal of the panel is to talk about provider consolidation, which is one area of concern and possibly impacting prices. And, I think that would be, maybe something that the panel can touch on, or you can bring it up at that point as well. Okay, I think I'm going to turn it over to you.
Thank you very much, Jen. We're going to take a 15-minute break now, so we'll get started again at 10:30 here. So thank you. Again, there's some refreshments outside. 10:25? The report's going to be much shorter, so we're going to be fine with.
Oh, okay. Sorry.
All right, we're ready to begin. Next, we have our carrier panel with Harvard Pilgrim, Anthem, Ambetter, Tufts, and Cigna. We are fortunate to have top leadership from each of the organizations. The audience is going to have an opportunity to ask questions as well. There's some cards available, so if you do have any questions, please fill out these cards and pass them forward to Don Gorman, who I have. There he is, right there. The cards up there, or are these them? Yeah, thanks. All right, I'm going to first start by just introducing our participants. First, we have Dr. Bill Brewster, who's the Vice President of Harvard Pilgrim Healthcare, New Hampshire market. We have Lisa Gurton, who's the President of Anthem, New Hampshire. We have Jennifer Wagand, President and CEO of Ambetter. We have Jerry Vaughn, who's the President of Tufts Health Freedom Plan. And we have Mark Butler, who's Northeast Market President for Cigna. Thank you all again for coming. And all of their bios are available with the information that we have outside. So if any of you would like to read up on their accomplishments, please feel free to grab those. We're going to jump right into the questions here. So the first question is for Dr. Bill Brewster and Harvard Pilgrim. Generally, insurance is an industry that favors size and the associated economies of scale. Compared to a large national carrier, it would seem as though Harvard Pilgrim is disadvantaged. Please describe your relationship with United Healthcare and how remaining as an independent regional carrier could result in lower costs overall.
Thank you. Thanks for asking us to be part of this today. Thanks for all of you for coming. And again, I only hope I can do as good a job as was done in the prior presentation. I'm still surprised they keep asking me back, but I appreciate that. I understood the question, and I understand how that bigger sometimes is better. I think one of the things that we bring to the market as a regional player is that we really are local, and that we bring that value of actually being local and having what we do fit the market that we're in. I think most of you understand that we're in 4 states, in Maine, New Hampshire, Connecticut, and Massachusetts. But each of us has a VP that runs each market and a market team that is very local. So what we do is really adjusted based on each market, because even Maine and New Hampshire have different market segments, different market forces, different provider groups, and it lets us to really work with them. We have United as an overlay and a partner that allows us to sell to businesses that have satellite offices across the United States, and I think that helps us for those market segments that are on the bigger side, really work with them to be able to offer value outside of New England. I think one of the values, again, of being a regional player is that we really own where we play and where we work. We're part of those communities, but also we have teams like our pharmacy team. I don't know, those of you that are providers in the room, I know there are a bunch of you in here. Crises always happen about 4:30 on a Friday afternoon. When I was a physician and doing that, it always, I'd be thinking about the weekend and getting out, and my front desk would go, there's somebody really sick. Pharmacy questions, other issues around coverage. I had a person who works for another payer whose daughter actually had insurance with us, who had a crisis at 4:30 about a specialty drug they needed that weekend, and we were able to, I could make a phone call down to our office, speak to the second in command of our pharmacy team at 4:30. By 5 o'clock, we had an exception in place until the physician could get the information in that we needed to cover that. So I think we own that, and we own our networks. If you're seeing somebody, if you're in New Hampshire and you need to go to Massachusetts or Connecticut or Maine, we own that network. We're contracted directly with those providers in all of the states so that we have those direct relationships and can work to make that work better. So I think it's really, there's a value to us being a regional player in a marketplace, doing what we do for the segments that we feel are our segments to work in.
Excellent, thank you, Doctor. The next question is for Anthem, Lisa. Is Anthem in opposition to most provider mergers? And can you identify examples or evidence of provider consolidation that would make it virtually impossible to sell health insurance without paying high price demanded by a consolidated provider system?
Okay, so he gets a softball and I get that one. That's perfect. Well, you know what, I'll be honest, Anthem is concerned about most potential mergers on the care delivery side, and I would say that's based both on multiple independent national studies and analyses that pretty emphatically demonstrate that prices go up substantially following, those consolidations, but also on our own experience inside of Anthem, both in this market and around the country. So I'll just, to answer your question, I'll highlight a few examples of both. And some of it's very recent. So it was just this year that the Commonwealth Fund published a report that showed that concentration on the delivery side pushed up hospital prices, physician prices, and not surprisingly, Affordable Care Act premiums, because as we always point out, the cost of health insurance is directly tied to the underlying cost of health care. There was something else interesting that happened this year that I think brought out an important aspect of this that doesn't always get addressed, and that's Lee Moore Daphne, who's a professor at Harvard Business School, testified to the House Committee on Energy and Commerce. And he had a couple of important points. The first was that in general, mergers on the delivery side do cause increases in price. But one of his specific points was that even mergers that span distinct markets, and this is kind of an important point, do drive up price. Why is that important? Because often when you do an antitrust review of two organizations coming together, the real focus is, do they compete in their own footprint? Would this reduce competition? And that's an important consideration. But I think Daphne's point was it's not the only one. Because even if those merging entities are in completely separate markets, you saw how much of insurance is purchased by employers. And employers have needs for a network that spans multiple markets in order to meet the needs of their employees. They can't have holes in the network. It's that fact, as Daphne pointed out, that creates a real increase in bargaining power, even if the organizations that are coming together don't compete locally. I think if you want to put that in very simplistic terms, if a system gets big enough and covers enough of a market, you can get into a situation of sort of take it or leave it, because employers don't want holes in the network. In 2017, New Hampshire's own former Center for Public Policy Studies urged caution, said there's robust literature that reduction in competition and hospital consolidation result in increase in prices. And then I think we need only look south, because Massachusetts is one of the most studied markets because of years of pretty much unchecked growth by partners. In fact, I think it was 2014, the New York Times said that partners' expansion en masse actually should serve as a cautionary tale to other states about the risk of big hospital mergers, and also, importantly, the limits of antitrust law to do anything about it once a dominant system really takes hold. So, there's just lots of information available on that you can access. There was a health policy committee that looked at when Partners was looking to acquire South Shore and Hallmark, costs would go up by 23 to 26 million. So, ultimately the AG in Massachusetts said enough, and now we know that Partners is looking to other markets like ours and Rhode Island. So I'll stop there on sort of the national study perspective and just cite a few Anthem examples. One of the most interesting markets for us to look at as an Anthem market is California, because Northern California is highly consolidated on the delivery side, and Southern California is not. In the north, inpatient prices are 70% higher, outpatient 15 to 50% higher, and not coincidentally, ACA premiums are 35% higher in the north than in the south. Another recent study, we actually have an Anthem plan in Missouri, and a large hospital and a regional medical center merged, and we participated in a study to look at the prices before and after. These are real numbers. Inpatient before $1,200, after $2,500. Colonoscopy before $711, after $1,500. Maternity before $2,500, after $5,000. So with everything we heard earlier about the challenges of affordability, I would ask, how can we not be concerned? So generally speaking, that's the basis of the concern that we have.
Very good. Thank you, Lisa. The next question we have is for Ambetter, Jennifer. Dartmouth-Hitchcock is a large provider in the state with substantial integration. How do your negotiations with Dartmouth-Hitchcock differ from those with other providers?
Great, and thank you again for having us here today. You know, I would say that from our perspective, each provider is unique. And while there are providers that range in size and scope and availability of services, we really take the opportunity to have that relationship with our providers individually. We've looked at over the past couple months and years, looking at the surge in behavioral health and substance use providers and the different types of modeling that we need to afford providers of that scale and size versus someone of the scale and size of Dartmouth. Clearly a provider that provides a wide scope and service, multi-regional presence, and then we're also looking at the evolution and integration of alternative payment models and how they can come together and meet providers where they are, because an alternative payment model for Dartmouth may not be the same or effective alternative payment method for a smaller provider that's in the community. So we take all of those pieces and parts and really approach our providers with a consistent package and understanding what their drivers are, how do we improve overall health outcomes of our members, and align on a compensation and negotiation plan that works best for both parties.
That's great, Jennifer, thank you. Next question is for Jerry and Tufts. Have you faced unusual challenges from provider organizations that consider your relationship with the granted health providers favoring their competitors? And has that increased the price paid to those non-granted health providers?
Thank you for that question, and good morning. I'm really happy to be here and part of the panel this morning. So I would say that that question has been asked of me as I've been making my way around the state since I started with Tufts Health Freedom Plan in June. And I would say that I'm happy to report that we have all 26 acute care hospitals in our provider network. I would say that our network matches our competition, and so I'm not at all concerned with network adequacy. That being said, I think the question is fair, and I would speak a little bit to the unique arrangement that we have through Tufts Health Freedom Plan. I'm not sure if you're all aware of it, but it is a joint venture and it is a partnership between a well-established health plan out of Massachusetts, Tufts Health Plan, and then Granite Health, which is comprised of 5 hospital healthcare systems. And I think we have the unique opportunity to leverage that collaborative governance structure to really look at the marketplace and assess and understand exactly what the needs are for each one of the unique communities in New Hampshire. And I would say that the learning that we're obtaining through this model is helping us understand how we need to partner with providers across the state. Early signals are suggesting to me that there is strong support and engagement from providers across New Hampshire, and they truly see us as a viable option and a sustainable option. I think that when you look at competition, whether it be on the provider side or the carrier side, I think that the market is better served with more competition. We've been able to deliver a lower price point for the entire market, specifically in small group. And when I look at, we've got almost 950 accounts, largely in small group, where we have been able to provide an affordable coverage option for their employees. So I would say that we're embracing providers across the state, and I think they're embracing us as well. Thank you.
Thank you very much. All right, the next question is for Cigna and Mark. Thank you. Pharmacy benefit manager business practices have received a lot of scrutiny lately. Does Cigna believe carriers need to take more control of these operations, including dispensing of medications?
First of all, thank you everybody for attending here today. Thank you for having us. Enjoy speaking with this panel as we did here the last couple of years. So probably just a level set, Cigna historically and continues to own their own pharmacy benefit manager. So we own that component. And most of you probably are aware we've entered into an agreement recently to buy Express Scripts. So we will be, intention is to expand that capability. Can't elaborate on that because we're a publicly traded company, but we do expect to close that transaction by the end of the year. So I interpreted the question, Commissioner, in terms of dispensing. We have home delivery services that we provide through Cigna Pharmacy today. It's designed to be a more affordable choice. It's designed to be a more convenient option that's there. So when we think about access and ease and fulfilling prescription medications, we have a lot of data that suggests recurrent hospital stays occur because of medicine non-compliance. So when we think about access, oftentimes people can't get out and actually get the medication. or they take half of it, they don't finish it. Working in the Cigna pharmacy benefit business, home delivery makes it convenient, but we also have folks that outreach will explain how the medication works, make sure that people are compliant in taking the prescription to its completion, because its clinical effectiveness certainly is going to be much better. So I think when we look into the future, and we saw a little bit earlier today, we see some of those trends in the drug area coming down. At Cigna, at least, we will continue to own that component of the healthcare dollar as we go forward, and we're looking to make that experience from a customer and a user perspective as easy and as compliant as possible as we go forward.
That's great, Mark. Thank you very much. All right, question number 2 for Dr. Bill here. What is unique about the potential partners opportunity, and why would a relationship with a system seen as expensive result in lower costs overall? Wouldn't there be cost implications with more referrals going to partners hospitals?
So I was kind of waiting for the next softball.
Yeah.
Is there another question? No.
Let me see, I'll give you anthems.
So I was expecting the question. I've had the question a lot, like Jerry said. You go around, you meet with people, and the question is, what about partners? What about partners? And I go, what partners are you talking about? Big P partners, little P partners. Yeah. We have a lot of partners, and we are always looking. And to answer the question, there's no done deal. Anything we do with any partner, big P, little P, will bring value to the state of New Hampshire around cost, around quality. And so, again, if I knew the answer, if I knew what was going to happen with them, I would tell you. But we're looking to work with them like we do with every partner. We have a very, very successful, as people in the audience here today that are in partnership with us in Benevera Health. It has been driving down costs by any metric that you want to look at, whether it's readmits, ER visits, whatever. We do this across our membership. We identify people early, and we try to keep them healthy. And one of the things when we go into partnerships, whether it's with Elliott, whether it's with Dartmouth or Frisbee, or one of our other one-off pilots that we do with a lot of people around bundles, around ER utilization or whatever, when we look at those partnerships, one of the things as a provider that I think I bring, again, that value to the table is to say, well, we have to have something about what's in it for them. Us driving down their direct revenue has to come back someplace if they're still doing the work to keep people healthy. So how do they pay their bills? And how do we share in that efficiency that we develop? And I think that's, again, will have to be part of whether it's the big P partners discussion or whatever. There is no ability for me to pay more and more in premium every year, or as when I owned a business, for me to be able to pay more and more as one of the biggest line items they have, or as a partner out there, as a provider partner, to pay more and more bad, to absorb more and more bad debt. I know Sharon had mentioned that earlier. So these partners, whether it's the Big P partnership or other partnerships around Benevera, we're looking for those Benevera-like partnerships where we can find efficiencies, where we can legally align to actually drive down costs, direct revenue for people being sick, and actually have providers be able to succeed and survive when they keep their members healthy.
Thank you very much. All right, we have a second question for Anthem, Lisa. Do you feel that the Anthem business strategy is more or less focused on insurer-provider integration than your competitors? And I guess why or why not?
Well, I would say our focus has been on partnership, not ownership, and collaboration built around value-based payment and aligned incentives has been really important to us, and we have an approach that allows us to enter into those sorts of arrangements with the largest systems like Dartmouth, multiple hospitals represented in the room, with risk arrangements and bundled payments and the like, all the way down to the smallest independent practice. What I would say is a little bit different about the approach and the focus we've had is it's really focused on three things that we believe are really critical to improving the system and the performance of the system. First being fortifying primary care, which has really gotten sort of de-emphasized and devalued over the years. helping physicians stay independent. I'm going to talk a little bit about that one. And then, of course, rewarding value, not volume. We know that the fee-for-service approach that has been used in healthcare financing and delivery for years has some real unintended consequences, and that's where the pay-for-value becomes so important. But to talk about why those things are so vital and so central to what we've been working on, it starts with the fact that independent doctors, especially PCPs, are truly a vanishing breed. Nationally, only about 30% of doctors are independent, i.e. not an employee of a hospital or a large system. And I'll guest in up at Dartmouth Med School from time to time, and I'll sit with the students and I'll ask them, where do you think you're going to practice when you get out? To a person, no one says they're going to be independent. They don't even think it's a viable option anymore. I'm not going to hang out a shingle and go it alone. So this is a real issue. So why does it matter so much? MedPAC has said that as hospital employment of physicians has grown, services are migrating from office settings into hospital outpatient departments. And the same thing was reported in the Journal of Medical Economics. So their statement was, as PCPs become employees of a hospital, they're more likely to send tests and therapies and other services in-house rather than to other resources. So sort of plainly stated, the system begins to contain or control those referrals, creating a bit of a closed funnel. I have to caveat this to say I understand that. I understand the pressures on the delivery side that make that something that they want to do. And we're not sort of the enemy of those systems, but if you look at what happens to cost, the average hospital-based price for those services, those migrating services, can be double or more compared to independent community-based options. So things like lab and imaging, colonoscopy therapies. There's variation in general, but there's variation by site. So JAMA reported that as a result of that, the average total cost for a patient of an employed PCP is 10 to 19% higher than the total cost for the patient of an independent PCP. Again, that's something that we can't ignore. So one of our focus areas has been trying to make being independent a viable option by providing tools and support and information and, frankly, reimbursement to the primary care physicians that are independent so that remains a viable option for those who choose to practice that way. I think that's probably the most differentiating aspect of what we've been focusing on.
Very good. Thank you, Lisa. Next question is question 2 for Ambetter and Jennifer. Does Ambetter believe the integration of payer and pharmacy dispensing has the potential to increase drug costs or medical costs overall?
Well, it's certainly a heightened topic of discussion as of late, both locally and nationally. And certainly, we believe, and I believe, that integration and alignment from a pharmaceutical perspective with the health plan and health insurance industry can only improve total cost of care. So as Mark had alluded to earlier with the experience at Cigna, when we look at drug cost and we look at the blockbuster drugs coming out, and Hep C as example, Dr. Brewster and I were talking about that a little earlier today, and the migration and evolution of how Hep C has changed just over the last 18 months with new medications coming out. Having greater alignment between pharmaceutical and PBM services and health plan can only improve that total cost of care as we all work together to improve health outcomes. I think often too that from a pharmacy perspective that is often for us potentially the first time we interact with a new member. So they're going, while we're trying to outreach to them to welcome them to our health plan or orient them to services, they're accessing pharmacy services. So any alignment that we can do and build upon what we have today will improve those health outcomes and allow us to contribute even in a more efficient way. In addition to that, we're seeing a lot of great success with integration of medication therapy management programs, gaps in care, looking for opportunities to interact with folks as they fill or stop filling medications. What does that do to ED utilization, inpatient utilization, and outpatient utilization, and those drivers presented earlier by Jen and her team. So we think there's great opportunity to improve total cost of care, and that's really what we're focused on.
That's excellent. Thank you very much. All right, Cigna has the gold star 2 questions in a row here, so we'll start with this first one, Mark. Thank you. Cigna was quoted in a recent Wall Street Journal article describing negotiation strategies by large hospital delivery systems that prevented carriers from developing limited networks. Can you discuss this problem and how provider consolidation could make it worse?
So there's a lot in that question, and I think philosophically, staying with the quote that we did make in the journal is that what we believe in is we don't believe any significant system should be able to limit competition or drive pricing. Having said that, I think the panel's touched on a number of areas. The complexities inside of the hospital and physician systems today, first and foremost, can't be looked at really on a state-specific basis any longer. So we have plans, delivery systems down in Massachusetts that are going cross-border, down into Rhode Island, up into New Hampshire. And I think the way we should think about that is they're trying to define their geographic catchment area that they want to deliver services. Secondarily, they're looking to be price competitive and deliver access to care. Okay, it's debatable whether they're becoming too big, not too big, and what the overall cost in the market is of that. But I think the real grounded point here is that you have to look at it really not at a state-specific basis any longer, but an aggregate basis. Now, having said that, so why is size so important? So if you look at sort of the dynamics that have taken place in the national landscape, the ACA, you look at the different dynamics of what employers are looking for. Dr. Brewster alluded, whether they're looking for specialty services to be directed at certain areas. Everybody is really sort of transitioning right now to what do they want to be in the future. Okay, so that's a lot of the positional piece there. The question is as we negotiate with them, and everybody has a different approach, and we take different approaches based on the systems, the question will become, can we deliver an effective price, okay, for the employers? Number two, and I will talk about this very frequently, the employers are ultimately going to determine how much they're going to pay for what. If you look at New England right now, we still are largely an area that everybody wants every doctor, every hospital in. As the employers begin to compete in a global economy, and they have only X amount of dollars to put towards health care, okay, there will be an intersection point. Okay, we see it sometimes with different network configurations, but they're going to say, we want these systems, we don't want those systems. That will be the future at some point. We are not there yet. So we have the dynamics of what will the employers ultimately buy and accept? How do you balance access and cost? And then you've got the footprint that's ever changing that goes across states now with the delivery systems trying to position themselves as they go forward. So to sort of bring it back around to what the question was, and I think you have to answer the question on the context of understanding the landscape that we're operating in. Do we believe anybody should go in and be able to limit competition and set pricing? Philosophically, no. Okay, we don't like to do that. We believe, I think similar to other folks on the panel here, that competitiveness should be driven by delivering high value, okay, competitive cost, and be based on really a value-based delivery payment model.
Very good, thank you, Mark. And then the question 3, assuming you believe provider consolidation can drive up prices, do you pay the largest delivery systems the most for similar services?
So I probably covered a little bit of this in what I just spoke about, but very similar to what Jennifer said. Every negotiation is a freestanding negotiation. So I don't look at things as, are they bigger so they get more? Okay, are they smaller so they get less? We try to draw a balance of market competitiveness and fairness. I know there were some questions that came up on, how do you reimburse appropriately for services rendered? Okay, how do you set the right reimbursement level? How do you reimburse for the complex services that are rendered? Okay, so there's a balancing that goes on in that. So what I would tell you is I've been doing this for 40 years now, that the dynamics in the negotiations with the systems are very different today than they were even 10 years ago. And what do I mean by that? There's much more collaboration. I think everybody is trying to create a situation where they can be appropriately reimbursed for the services they deliver. We're trying to, as a health services company, to reimburse at what we think are appropriate levels that will address the needs of the employers that we serve. And I think we're sort of in a changing world right now. We're moving away from fee-for-service. We're moving into more value-based arrangements. That puts a lot of strain on both sides of the system. But I think we're making progress, sir.
Excellent. Thank you very much, Mark. And I think I passed over one question that I'm going to come back to for Tuss and Jerry. What kind of provider consolidation usually drives cost, price, or utilization the most, vertical or horizontal? And if you can, some examples.
So I would say it really depends, and to tee off a little bit what Lisa shared, I think historically there haven't been many data points that would suggest that provider consolidation and horizontal integration has really brought costs down. I think that if you look at market to market, there's enough data that would suggest it's actually going the other way. As providers affiliate, merge, and acquire, I think that there is a pressure to raise cost as a result of it, because typically these newly acquired providers fall under the existing contracts that are in place with those systems. So I would say that I don't see many examples where we've seen that cost has gone down. When I think about vertical integration, although let me just say this, I think lab may be an example. I was thinking about this question last night, where if you look at lab and you look at, and I think it's similar market to market, you've got LabCorp and you have Quest, who have been able to acquire very small independent clinical labs, and as a result of that, they've now got massive scale that they can produce a product that is really a commodity at that point. And as a result of that, they have driven costs down. They've been able to leverage their technology and their operational efficiencies to be able to offer a lower price point to the marketplace. So I would say that that would be an example of where price has gone down as a result of integration. When I think about vertical integration, and I think a couple of my panelists have also shared this, providers are challenged with the reimbursement models that are changing dramatically. And I think while we're all talking about the shift to value, the underlying payment structure is not set up that way yet. And so in order to achieve value across a continuum, you have providers that are acquiring DME and home health and skilled nursing. And I think the result of this is going to take years for us to probably see any type of cost efficiencies, but the goal is really to develop value across a continuum and be able to control that. When you think about on the provider side, what drives cost is IT. Many health systems across the country are now, they all have, interoperability was the buzzword about 3 to 5 years ago, and I think most of them are moving to Epic or Cerner, that's the Coke and Pepsi in the EMR world, and that's considerable, that's a huge cost structure that needs to be accounted for, and they need to do that to be able to support a new model of care and transform the delivery system, because the old system and the existing system is really still siloed based on a fee-for-service reimbursement platform.
That's great. Thank you very much, Jerry. So those are all the questions that we had as a department. Did anybody pass any questions down to Donna? Excellent.
Oh, yeah.
I can take it from here, I guess. I thought there was a wireless microphone. It's fine, I can take it from here if that's okay. Here it is. Okay, so I did receive a few questions here. The first one talks about, you guys have all talked about provider consolidation. This question is specifically about mergers of insurance companies, and they point out that the Department of Justice over the last few years has successfully sued to stop anti-competitive mergers between 4 of the 5 largest insurance companies. The questioner also goes on to cite a Health Affairs article I haven't fact-checked this at all, but basically they say that health insurance carrier consolidation has been more of a driver in terms of premium increases than providers. And they ask that each of the panelists discuss that.
Who's first?
I'll start it off.
Okay.
So maybe I'll start maybe with merger and acquisition piece first, and then maybe make a comment. So I think when you look at the market, and I think Jerry just said it best here. So you have a system that exists today that historically was done one way, okay? And I'm talking about the delivery side right now. There's huge investments that they're making to reinvent how they do business, how they align philosophies inside of the physician panels that are in those delivery systems, and then we've talked about really sort of geographic expansion. None of that comes easy, none of that comes inexpensively. So if you look at the payer side, and I'll speak specifically to Cigna, as we move into value-based reimbursement arrangements, as we sort of continue to support traditional fee-for-service arrangements, as we see the demographics begin to shift on employers, and I use this statement, by 10 years from now, 80% of the labor force will be millennials. So think about how that particular segmentation of people purchases, desires information, desires the transparency of it, the quickness. They want it delivered through a handheld. So when we think about the business that we're in, it's a very complicated business in its simplest form, both for the physician partners and for the companies like Cigna to continue to evolve and provide services, infrastructure, support for what is going to be needed in this business 5 years, 10 years from now. Now that could be, again, back to how we reimburse providers, how we send information out. Dr. Brewster made a comment, you know, when we look at New England, more and more employers don't have their entire employee base here. We're a global company. We operate in 50 states and in 36 countries. We have to be able to deliver services on a platform and an infrastructure that can service all of those individuals. So as we sort of look at you know, premiums charged, reinvestment of that capital, there's tremendous support structures that go into that and will continue to go into that as we sort of work and evolve with the delivery systems and really what the consumers of tomorrow will want.
And I would say, building on to Mark's comments, I would say that Mark's correct that the expectations are changing. The expectations from our members, our providers, and our customers. So when you think about, you know, our providers are seeking help with analytics to support the value-based contracts that we're trying to partner on, and our alternative payment models. Well, there's data, and data needs to be interchanged with folks. And how do you create that scale and technology footprint to afford that functionality out to the market? Members, to Mark's point, are expecting a more mobile experience, so infrastructure and technology that's needed to support those activities. And from a customer perspective, whether that's the customer is the state or an employer group, their expectations and the games are increasing, right? So we need to invest and have scale, and I think that part of the consolidation we're seeing in the industry is aligning around the ability to have that scale, reinvestment in tools and technology and analytics to help to support total cost of care and health outcomes.
So I'm just going to jump in quickly also, and I would agree with both the prior speakers, but one of the things that I think we've really looked at is that we've really thought of ways to have it not be us and them, so it isn't just providers getting bigger and bigger or payers getting bigger and bigger, but we've really tried to, again, integrate so that it's not them or us, it's us together. I think the other thing that we've thought of and continue to think of is diversification across different market segments. So I think about 10 years ago or so, we acquired Health Plans, Inc., or HPI, which does a lot of our self-insured business, and MedWatch, which is a care management company, TrustleTree, which is a counseling and coaching team. And again, for size, I mean, I think people think of us as little. We cover almost 1.3 million lives in our Harvard Pilgrim business, but with all of our other subsidiaries across a diverse market segment and different product lines, we cover over 3 million, touch 3 million people in the States. So again, I think that's been our plan as far as growing across the years.
I would say, to add comment to that as well, you know, I think insurance carriers are like other industries. in that we, the cost of technology to be able to be nimble and responsive to market needs is been dramatic over the last couple of years. And I think that in order for carriers to be able to compete and offer product to the marketplace, scale and operational efficiencies are equally important on the carrier side. I think for Tufts Health Freedom Plans, some of the examples where we've tried to be creative and innovative are the relationship and partnership that we have with the Granite Health Systems, as well as Northeast Delta Dental, where we are responding to market needs and market demands. That said, I think that as carriers consolidate and some of these mergers and acquisitions continue to take hold, I think it's concerning for a smaller carrier like Tufts Health Freedom Plan to be able to compete around some of those operational efficiencies that are being gained by that. So I would say that it's important for us to be able to be responsive to the marketplace, embrace and engage with our providers, and offer a price point that is attractive and sustainable.
So to bring up the caboose, I will say that I understand the pressures that exist throughout healthcare financing and delivery. I don't believe there's a bad guy here. Each participant in the system is looking at, what do I need to do in this incredibly pressured environment? And the pressure comes from the affordability and what we just saw. So I don't believe there's any malintent. I think what it comes down to is sometimes what's good for a participant in the system may or may not be good for the system as a whole. In general, I think that the big horizontal mergers, especially when you're talking about big players like an Anthem and a Cigna, get an awful lot of attention. They just do. I think, back to the question about horizontal and vertical integration, there are a lot of much smaller scale things that happen under the radar every day that I personally believe have even more power to ultimately drive up cost. And a simple example might be a small independent physical therapy practice that gets purchased by a hospital, and overnight the charges may start to get billed as at hospital rates with a facility fee attached. That's not going to make the Wall Street Journal in the way that a large insurer might, but it's real. And again, there are reasons for that. No one's out to be the sinister bad guy, but I think we see those costs. I think if you study the reasons for the things we're talking about, the cost variation, we talked about the ability of a Quest to, as one example of bringing down the costs of a commodity service like lab. And when I sit and talk to hospitals or the hospital association, they'll say, but they don't have the same cost structure burden we do. Of course they can meet a better price. And what I say is, in a market where over half of the customers are self-insured, with already the highest deductibles in the nation, there may be very valid reasons for the cost differences, but our customers don't care. They tell us they can't afford to care anymore. And so what we've really been trying to do is help consumers engage very differently in understanding those cost variations and give them the tools and the information and, frankly, the incentives to pay attention to that. Not because there's, again, something sinister going on, but because something in this whole cost structure has to give. So I think there's a reason that the big mergers get the attention and the other stuff doesn't. I think the motivations for all participants to look at coming together are similar when you get right down to it. It's the investment costs of technology and the opportunity for scale.
Thank you very much. These next ones sort of touch on what you're talking a little bit about. This is about cost transparency and transparency in general. The first one talks about the payer-provider relationships and whether or not the carriers are going to plan to promote transparency to ensure that employers and consumers understand those relationships. And the second part has to do with cost transparency and whether or not the tools that are out there are contributing to any of the trends in the insurance market and will engagement by the consumer bring the cost down.
I could. Well, I was going to say it sort of just builds on what I was just bringing up. I think it has to. I think that we know we've got the department's tool, the public use data set, which presents sort of an aggregate view, and I know Anthem and I believe others as well have made their own proprietary tools available that actually is able to use specific benefit plan specific, contract negotiated rate specific tools that allow people to understand their expected cost for various services at different sites of care. So that's one thing. People need a way to know, and I think that's an important priority for us. But they need a reason to care, and you could argue that the big deductibles in and of themselves are a reason to care. But we find it actually takes a little bit more than that. So in our case, benefit plans that are site sensitive, where the out-of-pocket cost tracks with the overall cost that will be incurred when that site is used. Programs like Smart Shopper, which are actually giving people incentive checks when they do the shopping and go to the more cost-effective, high-quality site. I mean, both of those programs are so important to us that they're embedded in our standard, fully insured, large and small group benefit programs at this point, and all of them are producing strong, positive returns on investment. We just have to help people understand that variability that exists and make informed choices. And they are choices. You can still choose to do whatever you want, but the cost should track, I believe, accordingly based on those choices that you make. So I think that is really probably one of the most critical things we can do right now in partnership with our consumers to try to help with cost.
Maybe I'll add a quick comment on that. I agree with everything Lisa said there, but again, at Cigna, so our profile, and you saw it in New Hampshire, is largely self-funded. So employers have a desire, because it's a self-funded dollar, for people to make better shopping decisions. So we have full transparency tools because we own every component of the healthcare dollars. And when I say own it, they're our own proprietary companies. So I mentioned earlier, we have our own pharmacy benefit manager, we have our own dental company, core medical, behavioral. So why that's significant is we have transparency tools, national tools that are out there that support cost transparency around each of those components, which are very important. That's number one. The challenge, and every employer will tell you this, is that with the tools out there, number one, how do you get people to use them? And then once they use them, are we sure that they understand them? Okay, and again, where we're moving to from a model perspective is we now have products and services that are available to actually provide, I'll call it really at a concierge level, the ability to help individuals go in, use these tools, help them navigate, help them pick a provider, help them understand an actual cost estimate that they get, and make the right informed choice. So as we go forward, I think we'll begin to see, at least we believe, much more intense focus on that customer, the user, and then maximizing the tools through the usage of them, not so much that they don't exist, but how do you get the utilization of them up higher to make more informed choices.
And I would agree with both Mark and Lisa in what they've said so far. We have, certainly there's the state website. I don't know if they track, if you all track how much people use and any idea of who it is that's using it. I think there's a lot of us data wonks that are out there using it from the insurance companies, kind of looking and seeing what's going on. But again, for a day-to-day person in my life, I'm not sitting around going, I'm bored and I need something to do. Let me go on a website and check things. And often I'm listening to my doc and it sounds like peanuts and wah, wah, wah. You know, even though I'm a physician, now they've said I have something and I have to go get some tests done, and here's where you go. So we do have something called Reduce My Costs. It's, again, it's incents people to actually go to some place that might be less expensive. We have nurses who actually staff those calls, so they actually will work as a clinician, somebody who's clinically trained to work with the provider to help transition someone. And I think, as Mark said, the self-insured business that we have, people are very concerned about that, and I think some of the larger groups will have such great HR teams that they will daily, not just at the health fair when we enroll some employee, but throughout the year reinforce that with people. I think we have to have that help to say, okay, there is this reduce my cost, we'll actually pay you for making the call. There are choices, you have a deductible, a lot of this is your money, but it's constantly reminding about people with choices, working with the HR, and we also have Ambetter on it's so different across the marketplace as to the help that employees have and members have. When you're an individual, you don't have an HR department, you are the HR. Or a small group that might have 3 people and the CEO of the company that's making whatever it is that they make for a product is more concerned about that. And so we have our Ambetter team that actually notice these patterns of high-cost, util, inefficient site of service, like Lisa said, that's just like, why would you go there for that kind of care? Going to the ER for a physical. And basically, our Ambetter team will work with those people to say, you know, you have alternatives, and give them a choice that they can do the next time to help train them as they get used to having insurance even.
Can I make a comment on that question as well? Because I think it's important. Our experience and what we've been seeing both in Massachusetts and New Hampshire is about 5%, 5 to 7% of patients, consumers actually tap into the transparency tool. And I think what's unique about healthcare is that when consumers or patients are shopping for a product or a service, it's not in isolation, and I think we need to be careful with what could be an unintended consequence of transparency. Hopefully transparency will drive costs down, and that the market will be competitive and providers will actually see what their price point is relative to their peer group or their competition. That would be the ultimate goal. I think what we need to be careful is that these do not drive further fragmentation in healthcare, because I think if you access a service outside of your local health system where your physician does not have access or communication with that provider or that other healthcare provider, I think it could ultimately drive cost in a different way. And we've seen this take place where a member or a consumer may have labs done at an independent lab, and then when they go and see their provider back in their healthcare system, they order the labs again because there's a timeliness that doesn't occur. And depending on how IT integrated the healthcare system is, it can cause fragmentation across the continuum.
And I think just to close that one out, not to repeat anything that anyone already said, but I think member engagement is critical, and we've talked about that. I think the other piece of it too is really leveraging our value-based contracts to push transparency to our providers as well. And we've seen a really great uptick in our new programs and our provider engagement around making those decisions as we push data to our providers, and if they're not aligned to a particular place, making that decision and helping members guide them through that process to make smart decisions. I think that transparency piece also encompasses our provider network as well, and sharing data with our providers.
Time for one more?
Sure.
This next one asks the panel, how are you working to support independent providers? Lisa mentioned earlier in her discussion about costs being 10 to 19% lower for unaffiliated independent providers, and this question is about how you guys are working to support those independent providers.
So I'll start. If you want to start?
Oh, go ahead.
You're the physician. Why don't you start?
You started first. Go ahead.
So clearly a key focus for us and an important part of the care delivery system is our community providers and non-affiliated providers. And certainly, you know, our approach has been to, again, meet providers where they are. Some of the providers that we work with are really grasping and interested in technology. I can't afford the technology myself, but how can you provide data to me to help influence decision making? We've also been very deliberate about not just looking at large regional providers for value-based contracts, but creating value-based contracts that can meet our small and independent providers, also within subspecialties, so our OB networks. How do we leverage value-based contracts there? How can we look at behavioral health differently? How can we look at our SUD providers in the SUD community that has become more and more robust within the last 12 months? How do we engage providers and really meet them where they are and provide value where we can? We have infrastructure that we can push around data and analytics, so they don't have to invest in that. And we've really been trying to be deliberate about how can we be helpful in the care continuum and not just be someone who's paying claims and, providing prior authorization, but how do we really transform ourselves to be more of a valued partner to our community-based providers?
And I would agree with everything you just said. I think that there's so many places that we can work, and we do work with different independent providers, whether it's a mental health center, whether it's an independent orthopedic practice. We do bundles, with independents. We try to design shared savings programs where we actually work with smaller organizations. And I think one of the toughest things about New Hampshire, and one of the great things about New Hampshire, is we have a lot of small, not only just independent, but very small provider groups that in aggregate don't have a lot of membership with one particular payer. It makes it really difficult to design a risk contract to get them to say, sure, share risk on 200 patients, when one of them getting sick or having an NICU baby is going to drive that contract. So we work on developing menus where our providers can actually pick from a menu of choices so they can align with what they're already doing and what they're doing with another payer to get paid for quality work. And then around substance use, we just gave out a bunch of grants for small organizations throughout the state that aren't classic clinicians that can bill an E&M code to actually help them do the work that they're doing around prevention and other things that might fall out of where we normally as an insurance company would be able to play and actually subsidize and support some of those initiatives that they're working with across the state.
So I'll say for Tufts Health Freedom, we're still an emerging carrier. We're growing in the marketplace. And for us, I think we look at the independent physician market almost similar to that of the employed. So it's a relatively seamless experience, and we're trying to make ease of use with us as a platform to assist them, knowing that they're challenged with, as you said, analytics, technology, reporting. You know, we've got some focus specifically on primary care, but I would say that it's really no different whether it be an independent physician or an employed physician. I think that our goal and our foundation is to really try and engage them around value and provide supporting reporting for them to be able to leverage and activate on that.
So I'll give New Hampshire credit going all the way back to the medical home pilot. Good results were seen across the board. Some of the strongest results were seen in the independent practices. That's consistent with what we're seeing in our enhanced personal health care program, where we see really all participants producing some really impressive results on cost and quality, but the very strongest are still the independents, with costs 11% lower than that program's average. So it's still there. How do we support it? I think you've heard it's about tools and information, reimbursement. One of the most important things is decoupling reimbursement from that 15 minutes when you're seeing a patient in your office, which you don't stop to think about, but that was really the only reimbursable event in a practice previously. And so now, with a monthly care management fee, completely decoupled from that, we're allowing smaller practices to have a new stream of revenue to invest in the things they need to do that total care management. And also giving them more insights and tools into what's going on with their patient population so that they can do a better job and be successful in those value-based arrangements.
I'd make just one closing comment because I agree with everything. I think when you listen to the panel, there's a couple things that I think are very clear. A, there's a lot of listening going on the carrier side of things. So, and two, it's a very complex business. Okay, so you heard about some of the challenges of trying to do value-based reimbursement with a small physician practice. Okay, challenge. So from Cigna's perspective, we're doing a lot of the work that takes place on the analytics side. We have 240 collaborative arrangements nationally. We have 30 collaborative arrangements inside of New England. We have 9 of those that exist inside of New Hampshire. They're anywhere from large systems to independent physician collaboratives. There's some very creative work we're getting involved with over in the state of Vermont that I think potentially has some cachet that carry over into other states in New England. Point really being is that as you think about sharing analytics, you sharing data, the goal really is to drive the lowest trends that we can possibly drive from a total medical cost management. And I'll underscore there, when we think about cost, and we think about cost of the future, think about it in terms of total medical cost. That's how a patient consumes, it's how they pick their place to go. It's working with providers to really reimburse them based on value, affordability, and quality. So I think, again, as we listen to the panel, I hope you can sense that there's a lot going on in the space. It's complex, but there's a lot of good work being done across the board.
Well, thank you, Don, and I want to thank all the panelists for participating. I really appreciate that. We're actually going to move right into the department's presentation on the discount study, and Tyler is back, so we're out of panic mode, and he could present it. So, come on up.
Great. I'd like to thank everybody for being involved in the hearing and all the work that goes into this as well. And you get a lot of thank yous from everybody who's up here. But I've been doing this for a while now. I think we've been doing this annual hearing and the report that goes along with it, probably for maybe 6 to 8 years. And I've always been very close to it and supervising a lot of the work that goes into it. We collected an enormous amount of data from the health insurance carriers, in part for this hearing, in part for what we call our supplemental report, which characterizes the market. And we collect a lot of claims data from the carriers too. And every year when we put together a potential agenda, there are always a lot of ideas about what we want to talk about, in addition to sort of the general overview of the healthcare costs and what's driving trends. And it's usually a pretty interesting conversation, and it's really challenging to narrow it down and keep sort of the scope appropriate for the audience we're going to have, come up with questions that the carriers can answer as honestly as possible, and get as much engagement as we can. I mean, we always want to kind of reach out to the provider community as much as others that may have a vested interest in whatever topic we have. But every year things change a little bit. We learn a little bit. We get a bunch of feedback from people. I'm not sure if it was mentioned, we've revised the report this year. The format's a little bit different. Hopefully it's a lot more digestible, and that probably won't be the last kind of iteration we have like it. But let us know what you think of what we put out there, what we produce, and if you have any suggestions for improvements in the future. It's very rewarding, though, to see it all come together, and first of all, for people to show up, the report to be produced, kind of information that we're able to provide to be beneficial. And it takes a lot of people and a lot of work to make it all come together. So I just wanted to address that. Of course, you can't anticipate everything that might come up in the morning, and certainly could have avoided some things this morning, but so far so good. So I'm going to talk to you about the insurance department's latest iteration of the provider discount study. We've actually done this kind of analysis a couple times before, but we do make use of the claims data that are submitted by the insurance companies, and the statute that gives us the authority to do that is really focused on improving sort of the knowledge of employers and purchasers and providers and insurance companies about cost drivers and what's going on in our market. And this is one example of what we do with those claims data. So the first thing I'd like to start with is just why we're actually doing this kind of analysis. What's our purpose? And the short answer is to gain some insight about the competitiveness of our market. Every analysis has its limitations, but it does provide insight that's been helpful in the past, and it's been able to provide insight about what may happen in the future. We do spend a lot of time working with the New Hampshire legislature and other policymakers. We often see legislation introduced that's intended to improve the competition in our insurance marketplace. We spend a lot of time explaining how insurance markets work, and this type of analysis helps us a lot in doing that. So it's not a new analysis. As I mentioned, we've done it before. We produced reports in 2010 and in 2012, and those reports are actually available on our website. If you haven't been there, go to the insurance department's website. On the left side, there is a reports tab. If you click that, you can see the reports we've produced year by year, and you'll have to go back to 2010 and 2012 to see the analysis we did at that time. But they're up there, and there are a lot of other reports that we've produced either directly with in-house resources or using external contractors, a lot of them using the claims data, and a lot of them do provide insight about cost drivers and what's going on in our insurance markets. So I strongly encourage you to take a look at what we've got up there if you haven't already. The current analysis was performed by Barry Dunn under the direction of the insurance department. Basically, we started with Barry Dunn, take a look at our last iteration of the report. Let's do something similar again and see what we've learned. All three of the analyses were done using what we refer to as the New Hampshire CHIS, the Comprehensive Health Information System, which is a robust claims database. Includes detailed claims that include what a provider charged, how much the insurer paid, what the member paid in forms of their cost sharing, as well as a lot of other detail about utilization and cost drivers. All anonymous data, so we can't tell who anybody is in there, but we can track changes over time, and we can look pretty closely at cost drivers. So why are discounts important? One of the first things that's important to realize about the way insurance works is that most of our premiums go out in terms of healthcare claims costs. So when we think about the competitiveness of our insurance markets, It's very easy to assume that, geez, those insurers have tons of money. They must have lots of flexibility about what to do with all that money. But the reality is it's something a little bit different. If we imagine a world where two insurance companies are operating and everything is the same, in other words, their covered populations have the same healthcare needs, the benefit designs are the same, cost sharing is the same, their networks are the same, everything is the same except what they pay for healthcare services. And the discounts lend some insight into that. And you can see that in this example, carrier B pays about 12% more on average for their healthcare services than carrier A. Because carriers need to spend under the ACA 80 to 85% of the premiums on medical claims costs, and they usually spend a little more than that. Typically the average is close to around 13%. There's so little that they retain to make up for competitive deficiencies that they might have, such as if they're paying for healthcare claims costs at a higher level. And so if the premium is set at the red bar that goes up and down, the horizontal bars are how much is spent in medical claims. You can see the difference in the outcome for each of these carriers. It's a 5% loss for the one on top, carrier B, and it turns out to be a 5% profit for the one on carrier A. Again, just a 12% difference in what they're paying for claims. And if you look at the note down at the bottom, an example of a 12% difference in payments to providers might be a 40% discount versus a 33% discount. So again, everything being equal, which is normally the reality, but the discounts provide some insight about what carriers are paying and how they compare to each other. So like I said, we did these analyses a few years ago, and so we have some knowledge that we have based prior discussions and conversations with the legislature as well as other policymakers on. And this dynamic, this graph, is one that probably a lot of you have already seen, but it's worth revisiting because I think it does share kind of what we've learned about discounts and market share. So this was the PPO product line using 2011 data, and it was produced in the last version of the report. And so when you look at the red bars, those are the average discounts that each of the carriers got with healthcare providers for PPO. At the time, there was a big difference between what PPO reimbursement was and HMO, at least with some carriers. HMO tended to be the most aggressive, in other words, the deepest discounts. But we tried to keep things as comparable as possible. And you can see that the big three, the one everybody's familiar with, Anthem, Cigna, and Harvard, all had the deepest discounts. You can also see the blue bars being a proxy for market share. Those are also the three carriers that carried the most weight in their negotiations with the healthcare providers because they had the greatest number of members that they could potentially shift to another provider. You can see that in some cases, even national giants like Aetna, who don't have much of a presence in New Hampshire, weren't able to get the same level of discounts. And that's largely true still today. You can also see that MVP, since left our market, was not really competitive with the big three, and certainly their provider contracts may have contributed to the reasons they had to leave the New Hampshire market. New Hampshire Health Plan was just a high-risk pool, which operated at the time. Anytime you do an analysis, there are always limitations, and people love to point them out, particularly when the facts don't support the position that they'd prefer to be in. So some of the limitations in doing a study like this, and in New Hampshire we can probably do it, and when other states can't, but there's still sort of limitations we have to watch out for. The first is carrier market share by hospital varies. It can vary some, it could vary a lot. And if you're dealing with a different amount of market share, it's going to weight the overall discount differently. And of course, the hospital charges aren't standardized, so one discount in one hospital isn't necessarily equivalent to the discount in another hospital. Clearly, the networks may vary. New Hampshire tends to have a more robust set of provider networks than what you see in a lot of other states. But that is also a consideration and potentially a confounder. And then, of course, provider contracts may differ in ways that can't be detected by the claims data. So claims data may represent sort of interim payment, and there may be some sort of incentive payment at the end or even a kind of a risk reduction. One of the other limitations is that prescription drug costs weren't included in this analysis, and they weren't included in the prior analysis. So when we think about sort of carrier competitiveness in the market, prescription drug costs are often 20% of the premium, so it's certainly a larger piece to leave out. But again, we're just trying to get insight about what's going on in our markets. The other elephant in the room is that the claims data are historical, so it represents the past. It doesn't necessarily represent today's world or the future. a little like driving with your rearview mirror. I mean, it's better than nothing, but you got to be careful where you're going. And then, of course, overall discounts could be influenced by deep discounts with large hospitals. So if an insurance company made it a point to get a really good contract with the largest players in the state, at least really good compared to the competitors, that's going to influence their discounts, and maybe a different story with other providers. And one of the other sort of notes of caution in looking at these kinds of results is that they're not highly suitable for employers to use. So if you've got a self-insured employer operating in the Seacoast and you're looking at whatever carrier appears to have a great discount, that may not represent the discount that that carrier has with the Seacoast hospitals where your members, your employees, are going to end up going. So just a word of caution. It's very useful from a high-level policymaker, insurance regulator perspective, but we wouldn't encourage an employer to use these data, at least not from the findings we're producing. Okay, so before you do the analysis, you know there's going to be limitations, you know there's going to be certain risks. We wanted to check a number of things, and we did that, or Barry Dunn did it for us, and to make sure they weren't going to be, again, confounders that would throw our findings off. And the first one goes to the fact that historically carriers would sometimes pay a healthcare provider more for their self-insured accounts in order to get a deeper discount for their fully insured business. And there have been representations that doesn't exist anymore today, although some folks still believe it does. We did look at the claims data, and if it exists, it's not substantial enough to throw our results. So whenever you're doing an analysis like this, you have to make decisions about whether or not you combine data and just aggregate it, and you deal with sort of the results and the findings at an aggregate level, or you start to split the data and say, well, for this population or this pool, the answer was this, and then for this one, it was this, and they might be different, but anytime you start to split the data, you deal with more variability. And so in other words, you just deal with smaller numbers. So the differences you're looking at might not be real. They just might be normal variation. You're always better off aggregating data as much as possible, as long as you don't believe that there are underlying differences. It's sort of like when you think about a survey, you know, the more people that are involved in the survey, the better your information is likely to be, or at least a higher response rate. Like I said, historically, there used to be different reimbursement levels depending on whether or not the product was considered an HMO product, a point of service, or a PPO. We took a look at that, and despite that last iteration of the report, which there definitely were differences in 2011, they don't seem to be at least substantial enough to still be relevant today. We also looked at that question about market share or use of the different hospitals, the distribution of a carrier's use of different hospitals, and that also was similar enough not to be a concern in the analysis. Finally, these are claims data, and anybody who's used claims data knows you see a lot of funny things in claims data. Just what's going on here? Don't know. Okay, well, does it happen often enough it's going to be a problem? You have to make a judgment decision about that. We have a lot of different ways of paying healthcare providers. Discount from charges is nice and straightforward. We've got DRGs that pay on a per case. We may have per diems. Who knows? Maybe we even got episode-type treatment methodologies. We're telling carriers how to submit the data using fields that exist on one of two standardized claims forms. A carrier could submit data incorrectly to us because they're paying on a DRG and they didn't quite read the rule correctly or didn't understand it the same way. So we looked for those kinds of variations, things in the data would throw our results. And indeed, we actually found one of the carriers that was not reporting their DRG-based payment the way we expected. We were able to work around it and get the carrier to submit their data correctly going forward. But it was something that Barry Dunn spent some time looking into, and it's always necessary whenever you do an analysis using the claims data. And just because it didn't exist a year ago doesn't mean it doesn't exist now. So you always have to do it every time you do an analysis like this. So what was the strategy for the current analysis? We knew going into this that the reimbursement rates to providers were likely to be different between the individual and group markets. So we'd separate the results by individual and group markets. Indeed, the competition in each of those markets is a little bit different, the players, the carriers. We would include as many carriers as possible, including some of those who have left the market. We have noticed over the years that the carriers without competitive discounts tend to struggle on an ongoing basis. And whether or not that's the only reason they leave the market, well, probably not, but it may have been a contributor. Since we haven't done this for a while, we also thought it'd be helpful to look at a few years worth of data and see how things have changed. When Barry Dunn ran the analysis, we used the most complete data we could in 2017, but it was just through October. So some of the data I'm going to show you is for calendar year 2016, seeing that it would be an advantage to use a calendar year's worth of data rather than just the 10 months. We also decided to break down services into broad categories to better understand how those discounts flow through from different provider groups. All right, a lot of background, now I'll jump to the results. Looking at the group market, this is what it looks like. So going from left to right, you've got the health insurance carrier. You've got each year, 2015 and 16 are each calendar years of data. Then you've got that January through October of 2017. Finally, in the final column, you've got the aggregate allowed amount of dollars. So it's a little bit of a proxy for market share, and but of course it is over more than a year. But it also gives you a sense of potentially how much weight each of these carriers have in their negotiations with providers. You can see Anthem is in a very strong position in the group market. And looking at 2017 with an average discount of 48%. As you go from there, Harvard's in second, but a 4 percentage point difference is substantial. Cigna and Tufts are pretty close at 42%. Aetna tails a little bit behind at 38%. United 34%. Minuteman, no longer in the market, 41%. Overall average of 45% in 2017, at least during the year of data we looked at. If you looked back at the prior years, there are some differences. There are some changes among the carriers and among the years. You do see an increasing average discount looking at each of those years. That doesn't necessarily mean that the carriers are paying providers less. It's, remember, discount is going to be a ratio. So to the extent charges are going up, payments may just not have gone up as quickly. So you end up with what looks like a deeper discount by year. And for those of you who benefit from a visual demonstration, this is basically the prior chart shown visually. So again, you've got Anthem all the way to the left. That line that goes down through is the proxy for market share. And you can see how they compare to each other. But you can see that there is definitely an association between how much market share, how much bargaining power the carrier has, and then, of course, their ability to extract a better discount over time. And you can see Minuteman all the way to the right, relatively small market share, particularly in the group market. And but their discount looked a little better than United Healthcare or Aetna. Looking at the individual market, we thought the discounts might be deeper, and indeed the data proved that to be the case. We see, though, that Anthem is, again, in a strong position in the individual market. We do see, though, that Ambetter is pretty close, or I would consider equivalent. Remember, there's always going to be a little bit of noise in these numbers, so 1 percentage point difference may not be sort of real. I mean, to the extent we're looking at some of the reasons for some noise or some variation. But Anthem and Ambetter, very close in 2017. Again, pretty close in the prior year as well. Harvard, again, behind Anthem. And then Minuteman, pretty close to Harvard, but still what appears to be a bit of a disadvantage. And again, when you look at all individual policies, you look at the discounts over time, you do see an increasing discount from charges, but again, doesn't necessarily mean that the carriers are paying the providers less. In fact, that's most likely not the case. When you look at the display graphically, you can see a similar relationship to the group market. However, you do see that Ambetter, despite having a lower market share, and again, this is commercial market, does seem to have that discount that's competitive with Anthem. Remember, they're also in the managed care side of things for Medicaid. So when they're negotiating, when they're thinking about network development, they're putting together contracts. They are negotiating for more than their individual commercial population. And as we think about insurance and this type of analysis in the prior years, it's certainly been relevant when an insurance company offers more than just the product. Clearly, it may have different terms depending on the type of product, but overall, the contract negotiations, decisions about reimbursement levels are being done at the same time. So again, looking at 2016, not 2017, we're just talking about 2017, but the group market, and when you start to split the types of reimbursement to what type of healthcare provider it is, these are how the breakdowns take place. And I think it's, again, I mean, physicians' charges aren't going to be equivalent to a hospital, but to the extent the carriers differ, that's what's going to be more important. So if we're looking at Anthem, again, strong position 2016. They have a particularly strong position when you look at discounts for professional providers at 51%. And that compares to, as you can see, the other carriers as you go down the spectrum. Things change a little bit depending on whether you're looking at hospital inpatient or outpatient. Other facilities up there, although it's a much smaller percentage of the total dollars, and the all services is just the overall discount. And you can see how things play out among the carriers and among the types of service. If you're looking at the 2016 individual market, similar story, just deeper discounts and fewer carriers. Community health options is also listed on there with Minuteman, even though, again, they're not in the markets, but you can see how they compared while they were in the market in 2016. So where do we go from here? As I mentioned, we've done the kind of analysis before. We'll summarize the findings, include them in the general cost report. Remember, what we've published so far is a preliminary report. That has to do with we're supposed to produce a report by November 1st, and so we produce a preliminary report. We have the hearing, may include information from that, and then we produce a final report. Also gives us a chance to receive comments from people who attended the hearing. Certainly we can consider that kind of information as well. These slides, or some of them, may be used during testimony and presentations with the legislature or other policymakers, the public. And I recognize a lot of you, so a lot of you know I'm giving those kinds of presentations and testimony. And it's very helpful, again, for explaining how insurance markets work. We often have at least the perception that if New Hampshire had 10 insurance companies, all with equal market share, so say 10% of the market, that our health insurance premiums would be less expensive than they are today. This kind of analysis demonstrates that if all the carriers are getting the same kind of discount that Aetna did, we'd probably be more likely paying more for our health insurance premiums. So it's very important to understand how our markets work, and New Hampshire's not unique in this context. About 99% of markets across the country are dominated by 2 or 3 carriers. It obviously has a lot to do with network development. The analysis may be updated annually and included as a part of the hearing in the report. We have a specific statute that calls for the insurance department to do this hearing and produce the report. It includes a requirement to do analyses that are very much consistent with the discount study. It obviously, like I said, has its limitations, but it does provide some insight into what we know about our markets and the way insurance works. So it's brief. I know I spent more time on the background, but anyway, I'm happy to take questions and go from here. Paula.
Tyler, clarification on the individual market. Does that include the health protection plan, Medicaid expansion data, or not?
It would for, see, that was 2016. So yeah, so to clarify for everybody's benefit, you've got a Medicaid population, the expansion population that is in the commercial market. So DHHS is essentially a purchaser of commercial health insurance, and the reimbursement terms should be the same or similar for that population because, again, it's a commercial population. It would be different than potentially the managed care organizations administering the benefits and contracts purely for their traditional Medicaid coverage.
Add a caveat to that, though, because from the provider perspective, and for those that don't know me, I represent the Hospital Association, there was a caveat relative to Medicaid expansion when that was approved by CMS that required reimbursement rates to be a certain level, which are more related to Medicare. And so I think that, honestly, I would argue, skews that data. So it's going to be out starting in 19, but I think it could skew the data.
So to repeat back to you, you think that the discount would be lower without that term in there or higher?
It's going to skew it. However, I mean, I don't know the different, negotiations obviously, but it's very specific that it's more Medicare related rates
for that population, which, and you don't have the rest of the Medicaid population in there. I believe it skews. There are other hospital contracting folks here that may or may not agree with me, but I think it skews the data.
I understand. Thank you.
That's all.
Lucy?
You may have answered this when I was out, and I apologize.
Sure.
So these are discounts off of charges.
Yes. Yep.
How do you account for the different, charges, such a random price point? Did you ever consider doing it as compared to the Medicare as a?
Oh, wow. Yeah, so the big question of that is making sure that we've got kind of a similar distribution, at least among the hospitals. It's sort of funny when you look at how an insurance company distributes its payments across the system, and you'll find that every provider is such a small percentage of the total. It gets so diluted in terms of the impact. It's kind of, but that's really one of the things you need to watch for most. In other words, if Anthem sent all their business to one part of the state and Harvard had all of it going to a completely different system, those two system charges would be most likely different even in aggregate, and so one discount wouldn't be equivalent to the other. So that's essentially the way it was done. Looking at sort of a percentage about Medicare is an interesting idea on a scale at this level of scale, because you'd be looking at more than professional reimbursement. You'd be looking at hospital reimbursement, inpatient and outpatient. You'd be looking at other kinds of providers. I will tell you that the department has done additional analysis at the professional fee schedule level, and we do see some consistency in the findings between what's been presented here and some of those other analyses. Those other analyses were done for a very different purpose, but it's still interesting, and the approach to that was looking at sort of a Medicare plus % amount. Yeah. Any other questions?
I guess
I'm sorry.
The comment. We're talking about the insurance discounts and how they need that to, continue to provide service and coverage and blah, blah, blah. But, providers go years sometimes without going up on their rates, or they don't do the cost of living rates or anything, yet the carriers are consistently dropping their reimbursement. Now, mind you, every year we have different requirements that go into us providing that care, and we're still supposed to do it under the constraints of that same little payment, and they're kind of making their own rules. And when you ask for the transparency, how are you coming up with this is based on Medicare and the marketplace when I can't get them to give me that information? Like, show me the dollars and cents, because when I send you the Medicaid rates and you are paying under Medicaid rates, that does not tell me that you're using those to find what our reimbursement should be. And when I get a reimbursement form from a patient and it stipulates on it, this is how much you saved, it makes the provider look like we are way overcharging and gouging the patient when we're literally getting $600 or $800 for doing a surgical procedure under sedation. And that patient thinks that we're overcharging. What about the carriers actually working with the providers? We're supposed to be trying to work for the same goal, but it doesn't feel like that's what's occurring.
Thanks for the comment. And this is actually a hearing, and we do dedicate the last portion of the hearing to comments. But thanks for your contribution. So at this point, let's stick with questions, and then we'll transition into the comment period and open it up.
I know it's a small number at this point, but does your data include the Medicare Advantage plans?
Yeah, good question. So Medicare Advantage is not regulated at the state level, and it does not include the Medicare Advantage data. Yep. All right, unless there are any other questions, I'll pass it back to John. We can open it up for any public comments.
As Tyler mentioned, we're going to move now into public comments. So if you would, So if you would like to make a comment, please identify yourself and speak into the microphone.
Lynn Beatty with Mid-State Development Corp. in Plymouth and Bristol. I just would like to say that the quality of what's on the website and the accessibility and the relevance to our patient and the reading level of all that has improved dramatically, and I know it's taken a huge amount of work, and I thank you for my patience.
Thank you very much. Anybody else?
Can I just ask a follow-up question? Which website and which part of it are you talking about?
All the information they have for the patients about how to evaluate a plan you're looking at, what you should be mindful of, where to call if you need help, that kind of information for the consumer is just amazingly good.
On both costs or on the NHID website?
On the NHID website. Sorry, Tyler. I apologize.
Anybody else? All right, well, thank you all for attending. I think there was a lot of great information. We're going to be publishing some reports in early December, as I mentioned, and we actually will have written comments will be accepted up until November 13th, so that gives a couple weeks. There you go. So thank you again.